We definitely don't go over the anatomy of the digestive system at all, but we do focus a lot more on the physiology. We teach you cool things like how to poo properly, because most of you don't know how to defecate properly. So we actually have a lab on that, an entire lab dedicated to how to poo properly so you don't have a heart attack while you're on the toilet. We also teach you about the different types of gut motility. We tell you how and why you vomit, for example. So there's a lot more detail that we go into for the digestive system, and also drugs that target the digestive system, like antiemetics, things that stop you from throwing up. So let's get going. The entire digestive process, the processes, I should say, starts with you putting food in your mouth. That's what we call ingestion. And mechanical digestion begins in the mouth. That's where you start chewing up your food into a smaller bolus. And the word bolus is something I'm going to use to describe the food that you swallow all the way to the stomach. Once it's passing out of the stomach, then we call it chyme, and I'll explain why when I get to the stomach. And then once it goes into the large intestine, we now call it feces. So there are certain areas where it's a bolus of food versus chyme versus feces. Chemical digestion also begins in the mouth, and I'll talk about the different types of mechanical and chemical digestion all along the alimentary canal. That's a fancy term to describe your digestive system. Mechanical and chemical digestion keep occurring in the stomach and in the small intestine. So starting from the mouth, stomach, small intestine, mechanical and chemical digestion is occurring. In the esophagus, we don't have mechanical or chemical digestion. We just have propulsion. We have the food being moved from your oral cavity to your stomach. We do see absorption of some nutrients beginning in the stomach, but it's very limited. Most of the nutrients and water are absorbed in the small intestine. The large intestine doesn't really absorb a lot of nutrients. At best, it absorbs vitamins and some water. And I'll talk about the specifics as I go through the alimentary canal for each section of your gut. Whatever you don't absorb has to come out of your body, is eliminated as waste, and that's defecation. And that's basically what the sigmoid colon and rectum are for. Again, our alimentary canal can basically be described as the continuous tube going through your body. The alimentary canal itself starts with the mouth, followed by the pharynx, specifically the oropharynx and laryngopharynx. Then that transitions into the esophagus, which is behind the trachea, as we learned last week. And then we go to the stomach, the small intestine, all three parts, and the large intestine, which also has three parts. Then we lead to a special part of the large intestine called the sigmoid colon, and then finally the rectum and the anal canal. So that's the entire tube. Now there are accessory organs that are attached to this tube, like the teeth, the tongue, gallbladder, liver, salivary glands, pancreas. Those are all accessory organs. They are connected to the alimentary canal, but they are considered to be accessories. So we're going to start with the mouth. And of course, the mouth have teeth. Those are accessory organs. I'll go into details about the teeth and their anatomy on the next slide or two. The mouth or oral cavity has stratified squamous epithelium. The purpose of the stratified squamous epithelium is to withstand friction. A lot of the food that we eat is rough, like potato chips, for example. and there's a lot of sloughing off of the skin as we chew. So we need a type of tissue that has a lot of mitotic division, which is epithelium, and we want a lot of layers so that if we slough some off, we still have some layers deep to that. So it's stratified squamous epithelium. We also have lips and cheeks, of course, that help form our oral cavity. Oops. And let me get my highlighter. So some anatomical features of the mouth include the frenulum. You actually have 3 different frenulum. You have a frenulum, which is that little flap of skin that connects your upper lip to the gums of your upper teeth. You have an inferior labial frenulum. Labia means lips. So you have one that connects your lower lip to the gums of the bottom row of your teeth. And there's also a lingual frenulum, which connects basically the inferior portion of your tongue to the inside of your oral cavity. There are 3 different kinds of salivary glands that will be dumping. So you have 3 on each side, so 6 total. Not shown here are the parotid glands. There would be 1 on each side. But we also have sublingual salivary glands on either side of the tongue, just underneath. And we also have submandibular glands on either side. And those ducts where the saliva empty out for the sublingual and submandibular, they come out underneath your tongue. And my dentist thinks it's hilarious to press on those ducts and then squirt some of my saliva out of my mouth. I am not a human squirt gun, I keep telling him, but he thinks that's hilarious. Let's see, the vestibule of your mouth. The word vestibule means waiting place. And you have quite a few vestibules in your body, but the vestibule of your mouth is actually behind your lips, but in front of your teeth. Most of us don't store food there. So why it's called the waiting place or the waiting space. We're not usually walking around with unchewed meat in between our lips and in front of our teeth, but that's the vestibule. It's not until you get past the teeth that the food is actually in the oral cavity. Of course, we remember that the superior roof of our oral cavity has the hard palate, which is actually from the maxilla. And then we have soft tissue that forms our soft palate, and that part that extends down that we see in the back of our throat is the uvula. So in between basically the uvula and the hyoid bone, this space here is the oropharynx. And then from the hyoid bone down to the cricoid cartilage, this space would be the laryngopharynx. And then after that, we have the esophagus basically. Up here in the anterior side, we can see the thyroid cartilage, and then below that would be the cricoid cartilage. So I already told you about the vestibule and the frenulum, the 2 labial frenulum and the lingual frenulum. We have the hard and soft palate, and I told you we can see the uvula hanging down from the back of our throat when we open our mouth and say ah. Back where the uvula is hanging over, you have, I call them the golden arches, right? We think of McDonald's. And you have basically 2 arches that are in the back of your mouth. And in between them, you have a tonsil, the palatine tonsil. So the first arch is the palatoglossal arch, and then the one in the very, very back is the palatopharyngeal arch. And in between them, like I said, is the palatine tonsil. Now, when we look at your tongue, And in particular, I know Sarah has a few cats. I see one sleeping up in its little bed behind her. It's weird when our cats or our dogs lick us. Their tongue feels different than what we might anticipate. And it's because of these papillae. And the purpose of most of the papillae, these little bumps, papilla basically means like mushroom. So they look like little mushrooms growing on the surface of your tongue. They, for the most part, these papillae, specifically the fungiform papillae that are shown here, they are important, these fungiform papillae that really look like mushrooms. They have taste buds embedded in the surface of them. Foliate papillae also have taste buds that are found, but more on the lateral sides of them. And in your histology packet for lab 4, you actually do have a slide of the tongue showing you these papillae with the taste buds embedded in them. In the very back of your tongue, you have an inverted V, a very special papillae called velate papilla. And they also have a lot of taste buds along the lateral sides of them, much like the foliate papilla. The filiform papilla are the ones you're probably noticing the most when your dog or cat lick you. The filiform papillae don't have taste buds. Instead, their job is to act like a way to grip your food so that you can turn it over in your mouth and form like a round bolus of food before you swallow, make it easier to swallow. So they're your gripping mechanism of your tongue. And that's usually what you feel when your dog or cat are licking you, are the filiform papillae, the rough papillae. Yeah, that's what I want to say for that. The sulcus terminalis, just to say that, is this bare spot behind the velate papillae before you get to the root of the tongue. So it's that little bare inverted V just posterior of the velate papilla. The salivary glands, I told you, we already have, we have 3 on each side. So we have shown here the parotid glands. When someone gets the mumps, the virus that causes the mumps infects the parotid gland and they get very swollen. And you might remember old cartoons or old black and white TV shows like The Little Rascals, and when they got the mumps, the mom would tie a cloth around them and try and put pressure on those inflamed parotid glands. Underneath your mandible, you have the submandibular salivary gland. And then under your tongue, you've got the sublingual gland. There are 2 basic kinds of mixtures that we see for saliva. Saliva can be mostly water and digestive enzymes. We say serous cells that produce that. But we can also see some mucus cells in these glands. So we call them mixed glands. They have cells that are going to produce a lot of water and digestive enzymes, and then we have glands that are going to have a lot of mucus cells. The sublingual gland in particular has very few serous cells, mostly mucus cells. And that is part of the reason why if you go to get when you go to get your teeth cleaned, I don't know your preference, but there are 2 main ways that they clean your teeth these days. They can use the Cavitron, which is the supersonic machine that breaks up all of the tartar and plaque. So they use this high frequency sound wave. I can't tolerate that. I cannot stand that sound. So I have my dental hygienist hand scale where they get the pick and scrape everything out. I love it. They spend a lot of time down here on your 4 lower incisors, and that's because the sublingual gland, its duct, empties out just behind those 4 incisors. And because the sublingual gland is mostly mucus, producing cells. You get a lot of plaque buildup on the backside of those lower 4 teeth, and they sit there and they keep scraping and scraping and scraping, trying to get that all out. Just to pull from lecture unit 3, we do have parasympathetic and sympathetic innervation of these salivary glands. When you are getting up to give a speech, maybe for a speech class, you might notice that you're a little nervous, and the saliva you're producing becomes very scant but thick. So you get kind of that pasty mouth. So when the sympathetic division takes more control of these salivary glands, you still produce saliva, but it has a different consistency. It's more mucus than watery like. The digestive enzyme that we find in our saliva is called a salivary amylase, and that means you start to digest carbohydrates in your mouth. And a cool kind of experiment to do, because I know you're all so bored, you can take a cracker, chew up a cracker, just keep masticating it, just keep chewing it until it's just this liquid paste in your mouth. Don't swallow it, not yet. And pretty soon that cracker, that pasty bolus that you have in your mouth, will taste like sugar. And it's because the amylase is breaking down the carbohydrate in that cracker into simple sugars. And you can actually taste that with your taste buds on your tongue. So it starts tasting sweet, and kind of a fun thing to do. You produce almost a liter of saliva a day. It's really closer to 800 milliliters. And if you did not produce this amount of saliva a day, you would have an increased risk for producing cavities. The saliva that we produce not only has digestive enzymes, but also antibacterial agents. And this helps reduce the number of cavities we get. If you have allergies, however, and you take antihistamines on a regular basis, the antihistamines reduce the amount of saliva you make, and you will probably have a greater incidence of cavities. That's kind of the trade-off. So if you are taking daily antihistamines, please, please, please make sure you brush frequently and get a fluoride rinse, especially if you live in one of the cities where they don't add fluoride to the water. Huntington Beach adds a lot of fluoride to the water. And even if your city does add fluoride to the water, if you're not drinking your tap water, well, then it's not helping you, is it? So get some fluoride mouthwash and make sure that you are using it if you are taking antihistamines on a regular basis. So teeth, in adult teeth, so I'm not going to talk about our baby teeth, our deciduous teeth that we lose. We have 32 teeth total. We have, if I just count one quadrant of your teeth, you have 2 incisors, and then you have one canine, that's the sharp one, and some people actually file that so it looks more like fangs. Okay. And then you have 2 premolars that are posterior to your canine, and then 3 molars. The third one is what we usually consider to be your wisdom teeth. Some of you might have had your wisdom teeth removed. This is a common practice, especially if your mouth is not big enough for them to erupt. If they can't erupt, they can be impacted, or they might erupt horizontally. And if you have had braces and your parents invested in having you get this perfectly beautiful straight smile, when your wisdom teeth come in around early 20s is usually when they start to come in, it can make your mouth shift, and all of those braces were for naught. So it's very common before they start erupting that the late teenager goes in to get their wisdom teeth removed, especially if they have a small mouth and the dentist, orthodontist, is worried about room for them. The anatomy of the tooth, the part that we see above the gum line is called the crown. And then the part that actually starts to stick through the gum line is the neck. And the part that is found stuck within the bony socket itself is the root. Dentin is the material that makes up your tooth. It is a substance made of collagen and collagen-like components, and it is harder than bone. There is a cap on the top of dentin called enamel. Now, enamel is not dentin, and you can crack through your enamel. You can also wear it down. If you eat a lot of acidic food or drink acidic fluids like coffee or a lot of soda pop, it can wear down your enamel. You can also wear down your enamel if you are grinding your teeth at night and you don't grow that back. There's no getting the enamel back. You're one and done. So the enamel is basically on the crown part, and then the cementum that you can see in the picture here on the side, the left side of this tooth, highlighted in red here. That's where you would find the cementum. I like to think of it as the material that helps cement the root into the bony socket. There are cells that are responsible for making the dentin. Those are called odontoblasts. That name should sound familiar to you, a lot like an osteoblast, but this is an odontoblast. And there is, in the middle of your tooth, an area called pulp. And the pulp area here, the pulp cavity, there are a lot of blood vessels because we forget our teeth are living organs. And we also have nervous tissue, which is why if you crack your enamel and break through the enamel, the dentin that's there are these tubules. And these tubules are basically ways for nutrients to go from the pulp cavity and reach odontoblasts that are found scattered throughout the dentin, because they need nutrition too. If you crack your tooth and you drink really cold water, or you inhale air that might be cold, that coldness can travel, that temperature change can travel through those dental tubules. They're like little caves. And then you're sucking this cold air or the cold water, maybe when your dental hygienist rinses your mouth with the cold spray water and you're like, you have sensitive teeth. You probably have a little hole somewhere or cavity that's linking those dental tubules to this cavity, this pulp cavity, and that's where you're getting your sensitivity. Gingiva and gingivitis. The gingiva is basically the gum that we see in between your teeth. And when you get gingivitis, it is because you get bacteria trapped in between the gum, the gingiva, and the tooth. And the bacteria thrive. And they get stuck there, particularly with the saliva, with the mucus that our salivary glands are making. It's very important that you floss to help get that out. A lot of students also think that brushing real hard is good. It feels good, doesn't it? Sometimes when you brush real hard, but you shouldn't do that, because when you brush too hard, you irritate your gingiva, your gums, and they will start to recede and you'll get little pockets, which means you have a greater risk of bacteria getting stuck between the gum and the tooth. And that will cause irritation even more. And so the gum recedes even more. Your dental hygienist takes this tiny little ruler and puts it in your gum line and measures how much your gum has receded. You don't want to get more than 3 millimeters of recession of your gum. If you start to get to 4 or more, they start talking about procedures because they don't, you're going to lose that gum, and it protects your teeth, and bacteria will get into that bone. And then you're looking at root canals and stuff like that. So they actually can take material, gum, from other portions of your mouth and do a transplant. It is not fun. It's very painful. So don't brush too hard. Mechanical toothbrushes are the best to have, because then they vibrate and you're less likely to do this with your own toothbrush and overbrush or push too hard. You should definitely be flossing at least 2 times a day. And my hygienist says, actually, if you had to choose between flossing or brushing for the rest of your life, you could only pick one. She says flossing, because that's what gets all the material from in between your teeth and your gum the best anyway. So when she has patients that have receding gum lines, she actually tells them to brush less and floss more. So that's my little dental hygienist moment for you all. And I already talked about all those structures. Okay, the pharynx, we have seen this before when we went through the respiratory system. The pharynx has the 3 parts: the nasopharynx, the oropharynx, and then the laryngopharynx. The oropharynx is bounded superiorly by the tip of the uvula and inferiorly roughly by the hyoid bone. And then the laryngopharynx goes from the hyoid bone basically to the top of the bottom of the thyroid cartilage, top of the cricoid cartilage, roughly that area. We have different kinds of epithelium that are found in the pharynx. Most of the pharynx has stratified squamous epithelium. Certainly the oropharynx and laryngopharynx do. Why? Those are the structures of our throat where the bolus of food is traveling through, and that's very abrasive. But the nasopharynx itself does not need to have stratified squamous epithelium. And then also in the respiratory system, we talked about the epiglottis, which is elastic cartilage, and it's considered to be the guardian of the airway, because when you swallow, your throat muscles pull your larynx up superiorly, and as your larynx comes up, the epiglottis covers over the opening into your larynx and trachea. We don't want to aspirate the food we are swallowing. You can, however, have a moment while you're swallowing where this reflex can be circumvented. Not only when you swallow does the larynx come up and the epiglottis folds over the opening to the larynx, but your uvula swings superiorly. And this ensures that you don't have food shooting out your nose when you swallow, or food going into your trachea when you swallow. But if someone makes you laugh while you're swallowing and you start to laugh, you can actually have the uvula and epiglottis not cover things appropriately. I don't know about you, but have you ever shot food or drink out of your nose? It's not comfortable, it burns, and the reason why it burns is because that epithelium is not stratified squamous, and it's not used to having abrasive materials pass through it. And certainly if you get food aspirated into your larynx and trachea, this can be very dangerous because it obstructs airflow, and we want someone around that knows how to do the Heimlich maneuver on you. The peritoneal cavity. The peritoneal cavity is a slit-like space, a very thin space, and this space has peritoneal fluid. Peritoneal fluid is viscous. It acts as a lubricant. This is not the first time we talked about these potential slit-like spaces. The very first lecture in class, you learned about pleura. Sorry, not pleura. We learned about the visceral versus parietal membranes, and that there are different spaces in your thoracic and abdominal cavities that have these membranes around the slit-like space producing this lubricating fluid. And in the respiratory system, we learned about the visceral and parietal pleura. In the cardiovascular system, we learned about the visceral and parietal, pericardial membranes. And now in the peritoneum, we again see the same kind of system. We have parietal peritoneum, which lines the, it's just underneath the body wall. So shown here in orange all along is the parietal peritoneum. And then tightly adherent, shown here in the bright blue, is the visceral peritoneum. There are places where the peritoneum, where the peritoneum is basically doubled or folded over, and that's called mesentery. So I'm going to talk about the mesenteries now. The mesenteries, again, are double layers of peritoneum. And students ask, well, is it a double layer of parietal peritoneum, or is it a double layer of visceral peritoneum? Well, visceral peritoneum is only visceral peritoneum when it is tightly adherent to the actual viscera of your abdominal cavity. So we don't say, the point is it's just a double layer of peritoneum. There are two mesenteries that basically come from the ventral portion of the body wall. It doesn't look like it, but the lesser omentum is one, shown here. The lesser omentum, when you see it on the cat, it looks like a shiny film, almost like saran wrap, and it goes from the lesser curvature of the stomach up to the porta hepatis of the liver. And I'll remind you what the porta hepatis is in just a moment towards the end of this lecture. And we also have the falciform ligament. You can't see it on this picture, but the falciform ligament is a ligament of, basically it's peritoneum, that anchors the anterior side of the liver to the body wall. And I'll show you a picture of that when we get to the liver portion of this lecture. Dorsal mesenteries include the greater omentum, which is that apron-like sheet of peritoneum. The mesentery proper, which is the mesentery that is all around the small intestine. Some textbooks don't call the mesentery proper, they just call it mesentery. I don't like that practice because all of these are mesentery. It is more proper to say mesentery proper when you're talking about the mesentery within the small intestine, or I should say around all the layers or portions of the small intestine. The transverse mesocolon is basically going to anchor the transverse colon to the posterior body wall. And then lastly, the sigmoid mesocolon anchors the sigmoid colon to the back of the body wall as well. Here is the greater omentum, a dorsal mesentery right there. Up here is a ventral mesentery called the lesser, oops, I'm not using my mouse. It's around the lesser curvature of the stomach up to the porta hepatis of the liver. Here is the falciform ligament. It's in between the right and left lobe, and it anchors into the anterior body wall. Over here on the right of the screen, you can see the small intestine, and it sort of looks like, I don't know if you like mushrooms, but every time I buy oyster mushrooms, I think for some weird, sick reason, it reminds me of the small intestine with a mesentery in between it. It just kind of has the same kind of scalloped look to me. They are delicious. So all of this yellow stuff here has a lot of blood vessels in it, nerves, and it basically is anchoring all the portions of the small intestine together. Let's see, what else do I want to point out? The transverse mesocolon. So here's the transverse colon here. This again is in human. And so behind it would be the transverse mesocolon right here, anchoring it into the back of the body wall. I don't think that we are seeing way back here would be the sigmoid colon, and way back there would be also the mesocolon, the sigmoid mesocolon that's anchoring it to the posterior body wall. In your histology packet, you are expected to know the histological layers of your alimentary canal. They are broken down into 4 main areas. There is the mucosa, the submucosa, the layer where we find the muscularis externa, and then the last layer is the serosa. And the serosa would be the visceral peritoneum in most cases. The mucosa consists of the actual epithelium, which is usually simple columnar epithelium. Then we have a sheet of protein called the lamina propria that anchors those columnar cells at the basement part of the cell, or the basal layer, I should say. And then just deep to that is a smooth muscle layer called the muscularis mucosae. The muscularis mucosae is not capable of generating strong enough contractile force to cause the forward movement of the bolus of food or chyme or fecal material. Rather, it just has local contractions, weak local contractions, and most of its job is basically to help flick food, for example, back into the lumen where the digestive enzymes are. So those 3 things highlighted in blue, 7 through 9, are part of the mucosa. Then we get into the submucosa, and the submucosa has a sheet of nervous tissue called the Meissner's plexus. The better term for it is submucosal plexus. So again, it's a sheet of nervous tissue, neurons. And I'll talk about this more in just a moment. And then the actual area of the submucosa has things like glands that are producing digestive enzymes and mucus and that sort of thing. Then we get to the muscularis externi. So that would be items 4, 3, and 2 are part of the muscularis externi layer. There is a circular layer. The circular layer is going to help with squeezing on the food inside the chyme, and this helps with more mechanical digestion. There is a sheet, again, of neurons in between the circular layer and longitudinal layer. And this sheet of nervous tissue basically signals the circular muscle and longitudinal muscle to contract more. The longitudinal muscle and circular muscle are both smooth muscle, so definitely involuntary. And then lastly, the serosal layer is going to be either connective tissue that we call adventitia, or it's going to be the visceral peritoneum. Some organs in your alimentary canal are what we call retroperitoneal. They're behind the peritoneal layer, so they would have adventitia versus the serosal layer. And here is another picture showing you the different layers of your alimentary canal. We have this layer here would be the epithelium. And then we have a sheet of connective tissue that anchors it. That's shown here, this little purple part, oops, called the lamina propria. And then we have the muscularis externi. Sorry, muscularis mucosae. Then we have over here, I'll highlight over here. Hopefully my highlight will grab it correctly. Those two layers that I just highlighted are the muscularis externa. And there's an internal circular layer and an external longitudinal layer. This part down here in yellow is showing you the submucosal nerve plexus. It's deep to the muscularis mucosae. And then we have where we have a lot of blood vessels here, and that's actually in the submucosa. Then here is our circular layer of the muscularis externi. And here is the mesenteric plexus, this sheet of nervous tissue I was telling you about. And then the longitudinal layer. And then out here, this is where we would have the adventitia or serosal layer, depending on which organ we're talking about. These plexi that I told you about, the submucosal plexus and mesenteric plexus. This picture is not from your book. The picture down at the bottom is this picture up here showing you the mesenteric plexus and submucosal plexus is actually taken from our physiology textbook that we use. These neurons that you see here with their somas and axons and basically terminal boutons, those neurons are 100% contained in your gut. Every part of them is fully contained in the alimentary canal. Your gut has as many neurons as your brain and spinal cord combined. It is its own nervous system. It can basically, these neurons can cause the submucosal glands to release digestive enzymes. The neurons in the mesenteric plexus can tell the circular and longitudinal layer to contract more and increase gut motility. Those neurons in those plexi are not part of the sympathetic nor parasympathetic division. However, the sympathetic and parasympathetic division can communicate to these two layers. So they are considered to be extrinsic neurons that communicate to the intrinsic neurons of your plexi, or again, the mesenteric nervous system. Those mesenteric neurons, mesenteric neurons and submucosal neurons of the enteric nervous system, they can handle all matters of digestion and gut motility and secretion of digestive enzymes on their own. totally on their own. You do not have to have the sympathetic nor parasympathetic division to communicate with these neurons. They can take care of business. However, the sympathetic and parasympathetic divisions do influence them and can increase gut motility in the case of the parasympathetic division more than just background, or reduce gut motility in the case of the sympathetic division. So they definitely influence it. We say that the gut, sometimes we say it has a mind of its own, and it's not so much that it has a mind of its own as it has just control of itself, basically, is what I want to say. Food in, food out, everything that deals with movement of the food through the entire gut, those two plexi can regulate. Not only that, but the physical presence of food touching the epithelium of your gut can trigger sensory neurons that are part of this enteric nervous system and cause the release of more digestive enzymes or increased gut motility. Let me give you an example. I'll just shut up with trying to explain the science behind it, and I'll just give you an example that you can relate to. Have you ever eaten something, and by the you ate it, you swallowed it, and minutes go by, and all of a sudden you might be saying to people around you, something I ate doesn't agree with me. Or you might say something like, I think I'm going to see what I just ate all over again. The physical contact of food in your gut, the chemicals in the food, can trigger receptors and trigger these two plexi. So if you eat something that doesn't agree with you, these two layers of neurons are going to make sure that it gets out, one end or the other. So that's what I mean by they can handle everything. They can take care of business. And these neurons, there are also sensory components to them. So they do, go ahead, Sarah, unmute yourself.
Okay. It's not really a question, kind of a comment, and I really appreciate that example because, not me so much, but I feel like common thoughts typically are like when people say, oh, something made you sick, a lot of people don't think it should be that immediate. I have an older lady at work who's gotten a lot of food sensitivities as she's gotten older, and she was just complaining to me that she'll eat something and know immediately if she's going to get sick from it, and that she doesn't think people believe her. And I was kind of like, oh, well, sucks for you. Sorry, I don't go through that myself. But so exactly what you just said, I mean, that is pretty cool to learn. So anyways, that was it.
It is immediate. You also, of course, you first start to process the consistency of food. Like some people, little kids are really good. You give them something new and they put it in their mouth, and they will play with it for a while in their mouth. And they're learning, they're very oral sensory, and they're learning about what that food is. And sometimes when they're playing with it, they'll spit it right out, right? Like, give it back to you. Here you go. Not happening. Sometimes they actually swallow it a little bit. They swallow it, and then there are still some receptors in the back of your throat, and they are part of your vomiting center. So you have vomiting centers, or triggers, I should say, in your middle ear, like for rotational. Some of you get motion sickness, that sort of thing. You have some in your fourth ventricle by your medulla oblongata. If you drink too much, that gets into your bloodstream and also gets into your cerebral spinal fluid, and that fourth ventricle will detect that. If you drink too much, that's what makes you vomit. But you also have some in the back of your throat And so kids or anyone who swallows something and it hits the back of the throat and it doesn't, they will, and here it is. But sometimes as adults, we think that's not, that's not very polite to just, here you go. So we force it down, right? We force it down. And then again, you have receptors in your stomach, because the food's going to be there about 2 to 4 hours, depending on how much you eat. That's how long it takes for an entire meal to go from the stomach to the small intestine. So there's an awful lot of time for those receptors in the stomach to process if that food is agreeable with you or not. If it is not agreeable, again, it's going to come out one way or the other. If it's still in the stomach, it's going to come out through vomiting. If, however, it has moved through the pyloric valve and into the small intestine, it's going to come out probably, most certainly, as diarrhea. And again, receptors in the small intestine will register that. These neurons kick everything into action. It's like, out, out, we want it out. So yes, it is immediate. It is immediate. And absolutely, your friend is not lying. It's immediate. I love all things spicy. I love spicy heat. And although it burns my mouth and my mouth goes, why? I love it. I love it. And when it hits my stomach, I like the warmth. But then it hits my intestines, and my intestines, like my mouth, go, why? And I do, even though I love the spice, it causes increased gut motility because my small intestine is like, no. And I'll be damned if it isn't hotter coming out than it is going down sometimes. I get to relive it on the other end. It's just super fun. Anyway, so it's the law of the gut, and your gut has its own nervous system, and it takes care of business on its own. So now we're going through the gut still, and we're now at the esophagus, and it's a continuation of the pharynx, of course, and it's going to join to the stomach, and it joins with the stomach just below the diaphragm. And the diaphragm has an opening where the esophagus passes through to get to the stomach, and this is called the esophageal hiatus. Hiatus means break, opening in this case. Some people have a hiatal hernia where the upper part of their stomach slides through the esophageal hiatus, and some of the stomach actually ends up in the thoracic cavity. Almost every semester when we open up the cats, at least one cat has a hiatal hernia where some of the stomach is actually in the thoracic cavity. Sometimes the stomach can slip up and then slip back down where it should be, slip up and slip back down. That's called a sliding hiatal hernia. And to fix that is actually not very difficult. It's a very simple procedure, and they don't even have to cut you completely open. They can use laparoscopic technology to do this. Some at the bottom of your esophagus, it's called the lower esophageal sphincter. And there's also one at the top of your esophagus called the upper esophageal sphincter. It's not so much a true sphincter as it is just a thickening of the muscle, but that's still what we call it, a sphincter. And when you vomit, when you are about to vomit, you take a deep breath in and your stomach starts this massive contraction called retropulsion. It's basically flipping the contents of your stomach upward to reverse peristalsis. And when your stomach does that, you have to relax the lower esophageal sphincter. That part of your esophagus is involuntary. It's made of smooth muscle. But the upper part of your esophagus is voluntary, skeletal muscle. And you have to consciously relax the upper esophageal sphincter. Otherwise, as you start to vomit, the vomitus comes up your esophagus. And if you don't relax the upper sphincter, you swallow it back down. And when that happens, when you have vomitus coming up, you're retching if you're not vomiting it all the way up. And I assure you, when you realize that you just swallowed back down your vomitus, the next time you try, it's going to come up. That messes with your brain right away. The middle part of your esophagus is a mixture of skeletal muscle and smooth muscle. So it's like the esophagus transitions with the voluntary action of swallowing, and the skeletal muscle up at the top helps you do that, right? You have control of that. Then it transitions from skeletal and smooth to all smooth at the bottom third of your esophagus. So the swallowing, the proper term for that is deglutition. That's what it means to swallow. And once you put the food at the back of your tongue and swallow that bolus, we use peristalsis. And peristalsis means that the muscle behind the bolus of food constricts, but ahead of it, it relaxes. So that constriction at the back and relaxation at the front is what allows peristalsis to move your food from one part of the canal, your digestive tract, your alimentary canal, to the next part, the distal part. So the relaxation part is called reflexive relaxation, or some books call it receptive relaxation. And it's this peristalsis that helps get the food all the way through our alimentary canal, from when we swallow all the way down to our anus. That is not the only kind of gut motility that we have that we'll see. For example, the small intestine has something called segmentation, where different portions of the small intestine are just contracting, and when they contract, it's almost like it's like kneading dough, but it's kneading, it's contracting, it's mixing your bolus of food, your chyme, with digestive enzymes. Then there's a pendular motion, where the small intestines can have peristalsis that's going forward and backwards. So that's what we mean by pendular motion. Again, this helps with mixing. Retropulsion, I told you the stomach basically is churning, it's flipping the food. Retropulsion is very important for when we need to get the food up and out when we vomit. Now, I want to go back to this reflexive relaxation and give you a public safety announcement on this. When we eat, we put food in our oral cavity, we swallow, and that's the beginning part of peristalsis. Behind the bolus of food, there is a contractile ring, and ahead of it, there is receptive relaxation. This ensures that the food we swallow goes down our esophagus, into our stomach, out to the small intestine. When you swallow and eat, this wave of receptive relaxation ripples through all the parts of your alimentary canal. When it finally reaches your large intestine, it causes your large intestine to definitely start moving the fecal material along the large intestine and into the sigmoid colon. It's almost like your large intestine is saying, got it, we know more food is on the way, and we got to get rid of the old stuff to make room for new fecal material. So when you start to eat, within about 20 minutes, this reflexive relaxation, this ripple of relaxation hits your large intestine, and then that means all of the fecal material starts to move into the sigmoid colon. When your sigmoid colon is only about 25% full of fecal material, you get the sensation that you have to go big potty. So that's 20 minutes into your meal. Think about that. Next time you eat a meal, and I'm not talking a snack, a meal, 20 minutes into it, you're probably getting the sensation from your gut that you could go to the bathroom. Most of you don't pay attention to it at that point. Most of you don't, but children do. I promise you, when you have children and you go to a restaurant, the wait staff feel like they're doing you a favor. They'll bring the food for the child first, don't they? Right away, because usually the child is hungry and impatient. So your kid is eating while you're enjoying your cocktail maybe, and by the time your food shows up, it's about 20 minutes later, and guess what? Children obey the law of the gut very, very well. This food in, poo out, reflexive relaxation. So the irony is not lost on me that 20 minutes in, when your meal shows up, someone has to take that child to the bathroom. My mother always said, once you have a child, you never have hot coffee nor a hot meal again. And it's probably because you're taking care of that kid before you can enjoy yourself with a hot meal and hot beverage. So that's what we mean by the law of the gut. You start to eat, there is receptive relaxation that ripples, and you will have the sensation that you can go defecate. Again, most adults don't obey that urge. You pinch it back, as I like to say. This movement through your large intestine is called a mass movement. Doesn't mean that you're actually going to poo, because some of you say to yourself, oh, I don't want to poo at work, or I don't like to poo at school. I only like to poo in my own bathroom. I don't feel comfortable. You need to be careful with that, because the large intestine, if your brain basically says to it, nope, we're not having it, we're not doing this right now, your large intestine will get lazy, and it will no longer have this receptive relaxation, and it will expand with a lot of fecal material, and you will become constipated. Your feces will become hard and not as mixed with water, because the feces are there too long, and the large intestine keeps soaking up more and more of that water. Well, then you can't get mucus without water in your fecal material. So then it gets hard and crusty and impacted, and then that means it's very difficult for you to push that out. And when you are straining to defecate, you will learn in physiology, you are taking your life in your own hands, and you're causing a reflex to your heart where your heart can actually start working harder, and you can die on the toilet from straining too hard. People do all the time. Ask any EMT or paramedic when they get called in the morning and they are going to go pick up a dead body, 9 times out of 10, that dead body is in the bathroom next to the toilet. For sure. So here's another public safety announcement. Not only should you, like I just said, you should be pooing at least once a day. And if your gut is telling you you need to go, please don't be embarrassed. Everyone poos. Go poo. But here's the other part of that safety announcement. Be careful what you put in your ass. I mean, if you're into ass play, that's fine, but be careful, because it's true. This works in reverse. And there's a point where if you put something in your anus, that the receptive relaxation works in reverse, and as pretty soon your ass starts to go mine, and it just sucks it all up, like the seagulls from Finding Nemo. And then you've got some poor doctor that has to go Nemo and go in after that. People end up in the hospital having to get the strangest things retrieved from their rectum because of this law of the gut working now backwards. Usually right about now, I have a student saying, so if it works backwards, whatever I put in my ass, it's gonna come out of my mouth, right? No. There are some sphincters that regulate how far this can go back, and the ileocecal valve is one. So I have had students that work in hospital settings and have had patients come into the emergency room with light bulbs trapped in their rectum, flashlights, not little flashlights, mag lights. Let's see what else. Goldfish, and not the crackers. Let's see what else. Those were some of the pretty notable ones. So there are other times where you might be putting something in someone's anus, like for example, to get a temperature reading, right? A rectal thermometer, especially in young babies. So if you put that rectal thermometer in someone's anus because of this law of the gut, you might want to hold on to that, because mine, eventually it might just get sucked right. You turn and you come back and that thermometer's gone. And you're gonna have to go get that. I recommend double gloving. Anyway, so tie a string around it before you put it up there so you can retrieve it easier. It's just, oh, another one, soda pop bottles that are already open. You need to be careful because there can be a suction that's created and then you can't pull it out very well. So that's awkward. Anyway, be careful what you put in there is my take-home message. The stomach, onto a more G-rated thing. The stomach is lined with epithelium, specifically simple columnar epithelium, because at this point, we don't need to have we don't need stratified epithelium. We need simple columnar. We need more longitudinal cells that have more ability to produce digestive enzymes and absorb limited things. The stomach can absorb hydrophobic material like aspirin and alcohol, which is the reason why if you're in pain and you take some aspirin or ibuprofen within 20 minutes, because that's how long it takes to get to your stomach and be absorbed, it can cross the stomach lining into your bloodstream. Alcohol can also pass through the stomach lining and into your bloodstream, which is why if you are drinking on an empty stomach, you will absorb that alcohol very quickly within 20 minutes, and now you've got your full cocktail in your bloodstream. So you need to be careful with that. If you have food in your stomach, it tends to slow that process and dilute the alcohol. We have the lesser curvature shown here, and then over here, the greater curvature. The fundus is the most dome-shaped, and this part where the esophagus is coming through the esophageal hiatus of the diaphragm, that region is called the cardia or cardiac region of the stomach because it's close to the heart. Over here, this area, we have the pylorus. The antrum is the beginning part of it, and then we actually have the pyloric sphincter. The food that enters your stomach and gets mixed with all the digestive enzyme is no longer called food, it's called chyme. So once you get into the stomach, it's chyme. Once it goes into the small intestine, it still is called chyme. The muscularis externa of the stomach doesn't just have 2 layers, now we have 3. This is a unique finding. So the most internal layer is an oblique layer Then we see the circular layer, then the longitudinal layer. So 3 layers of smooth muscle. These macroscopic folds that you see, called gastric folds, they are more commonly called rugae. And the rugae help with allowing the stomach to distend. If you eat a big meal, it allows stretching, sort of like an accordion. Your stomach can either be like longhorn shaped, like the horns of a bull, so it lies more horizontally, or it could be what we call more J-shaped. And people who have J-shaped stomachs, if they eat a lot, their stomach can actually distend down into their pelvic bowl. That's usually the kind of stomach that people have when they go on those eating contests, like how much hot dogs they can shove in their mouth and their stomach. They tend to have a stomach that can elongate really easily like that and have a lot of rugae for this accordion-like opening. At the where we see the pyloric sphincter, another term for that is called gastroduodenal sphincter. The stomach has gastric pits, and depending on where you are in the stomach, the gastric pits, which are these invaginations, you can see in pink the simple columnar cells. These invaginations have different cells within the pit, depending on where you are in the stomach, and I'll explain in just a moment. So two different kinds of glandular pits. In general, the stomach secretes hydrochloric acid. The hydrochloric acid helps denature proteins, unravels them. You also have some enteroendocrine cells. That means endocrine, single cell endocrine cells that are in your gut, so enteroendocrine cells. These cells in your stomach release gastrin, a hormone. And gastrin tells cells called parietal cells to release hydrochloric acid. Parietal cells also release something called intrinsic factor. Intrinsic factor is necessary for the small intestine to absorb vitamin B12 from your diet. Without intrinsic factor, you cannot absorb vitamin B12, and you will get a kind of anemia called pernicious anemia if this happens to you. Another cell type in the stomach called chief cells, and I'll show you pictures of these, releases an enzyme called pepsinogen. The enzyme has two forms, a precursor form and then an active form. Pepsinogen, ogen, is the precursor form. When pepsinogen is activated, it is then just called pepsin, and it digests proteins. So in the stomach is where we first get protein digestion. We get the liquefaction of food, and I told you, depending on how big your meal is, this can take 2 to 4 hours. The average of that is 3 hours for an entire meal to get from your stomach through that pyloric sphincter into the small intestine. So these gastric pits, two different varieties of these gastric pits. So the first variety is technically called a gastric gland. So gastric glands are found in the cardia, the fundus, and the body of the stomach. So the gastric pits in these regions are now called gastric glands, and we see 3 different kinds of cells. We see mucus cells making mucus that helps protect the simple columnar cells on the surface of these pits. We see parietal cells that secrete hydrochloric acid and intrinsic factor. And the most numerous cell way down at the bottom of the pit of these gastric glands is the chief cell, which makes and releases pepsinogen. We also find, just to show you a picture of them, in a different gland, I'm going to show you a different gland on the next slide, those enteroendocrine cells. So those enteroendocrine cells, although shown here in this picture, they are not part of this gastric gland. They're going to be found in pyloric glands. Let me show you what that has. So again, the pyloric glands, they are going to be found in the pyloric region, which is the antrum and the pylorus itself. So 20% of the stomach has these pyloric glands. What cells do we find there? Mucous neck cells, and now those G cells, those enteroendocrine cells that release gastrin. And the hormone gastrin tells the parietal cell that's found in the gastric glands to release hydrochloric acid. Now, your stomach has simple columnar epithelium, and in between those cells are a lot of tight junctions. And this is to prohibit the digestive enzymes like pepsin and the hydrochloric acid from getting in between the cells and into the submucosa. But sometimes the protective barriers of your stomach, like these tight junctions, the mucus made by the mucous neck cells, and the high mitotic rate of the simple columnar cells, those are all protective barriers. Sometimes you can wear these protective barriers down and you start to have acid and your pepsin eating a hole, literally, through your stomach, shown here, and that's an ulcer. If it gets all the way into the submucosa, where blood vessels are, the blood will now leak into the lumen of your stomach, and you will have blood in your stomach and you will digest that. A lot of the iron will make you feel sick to your stomach, and many people throw up when they have a bleeding ulcer, and they throw up bloody vomitus. And a lot of times my students think, well, when you vomit blood, it's bright red. Blood from a bleeding ulcer is not bright red because your stomach has started to digest it. When you vomit this blood, it'll look like you're vomiting coffee grounds. That's what it's going to look like. So we have to be very careful in a clinical setting. When we ask a patient, are you throwing up? They say yes. Don't say to them, is there blood in your vomit? Because they'll think blood is bright red. And they might say, no, there's no blood in my vomit. Instead, you should say, tell me what your vomit looks like. Does it look like coffee grounds? If they say yes, that's basically blood that the patient has started to digest. You can also have an ulcer in the first part of the small intestine. And when the ulcer is found in the small intestine, and again, if it's a bleeding ulcer, the person will start to digest the blood, and now the blood will come out in their stool. And if you say to the patient, do you have blood in your stool? Again, they're going to be thinking bright red. Occult blood is bright red. It won't be occult blood. Instead, it'll be thick, black, and tarry, really hard to wipe up and clean from. And that kind of stool is called melena. So thick, black, tarry stool is melena. Don't name your child Melena. Now we're moving into the small intestine. The small intestine is named that not because it is small in length. It's actually very long in length. It's 2 meters long when you're alive, but it becomes 6 to 7 meters when you're dead. And students say, why? Does it grow when I'm dead? No, it doesn't grow. It's all of the smooth muscle relaxes, you know, like the circular muscle and the longitudinal muscle. And if the longitudinal muscle is relaxed, well, then it's a lot of intestinal length now. It's called small because of its diameter, very small diameter. It is the longest portion of the alimentary canal. Most of the enzymatic and absorption functions happen here. And there are 3 areas in order from proximal to distal. It's duodenum, jejunum, and ileum. The duodenum, shown here, that I'm highlighting now, translates into 12 fingers because it's roughly 12 fingers in width. Then we have the jejunum, which is shown here in purple on the picture, and then the ileum, which is the rest of this peachy red colored part here. Each part has its own physiology, if you will. The duodenum, mostly its physiology is all about receiving the contents from the stomach, but also the digestive enzymes from the pancreas. The jejunum is where most of the digestive and absorption functions occur, with the ileum serving mostly as a backup. Where the ileum connects to your large intestine is through the ileocecal valve, shown here. Looks like a cute little puckered set of lips. It's really unfortunate that we're not in lab, because I like us to, when we have the cat open, I tell students to cut open the first part of the large intestine and clean out the fecal material, just so you could see that cute little ileocecal valve. It just looks like lips puckered up, ready to kiss you. Not that you should, but it just looks darling. I think it's darling. The small intestine has unique microscopy. These some of these features are, most of them are microscopic, but we also have some macroscopic features. The circular folds, also known as plicae circularis, looks like corrugated cardboard here. Those kind of bumps that you're seeing are the circular folds. Villi, right here, villi are now microscopic. They are extensions of the mucosa. All of that purple stuff that you're seeing there are the simple columnar epithelial cells. And the blue cells that you're seeing there are goblet cells that are producing mucus. Down at the bottom, we have what's called intestinal crypts, or sometimes called intestinal glands. And again, down in those glands, we're going to see enteroendocrine cells. There are actually 3 different kinds of enteroendocrine cells producing and releasing 3 different hormones, which I will tell you about in just a moment. On the surface of the villi are extensions of the cytoplasm, shown here at the top of the simple columnar epithelial cell. Those are called microvilli. Between the circular folds, the villi, and the microvilli, the surface area has been increased dramatically in the small intestine, up to about 200 square meters. This helps increase absorption of your nutrients. So in order to absorb things across cell membranes, we need a lot of surface area to insert proteins that facilitate that movement. We learned about that in Unit 1. We learned about facilitated diffusion and endocytosis and exocytosis. So we need a lot of surface area to allow those things to happen. People who have celiac disease or gluten allergies, their immune system attack and destroy the microvilli. And the microvilli are, for such little things, they are the most responsible for increasing the surface area. So this immune response is an autoimmune response. And basically the microvilli are kind of shaved off. So the person loses a lot of surface area, and that means they can't absorb the nutrients that they just ate, not well at least. And if you don't absorb it, then all of those particles that aren't moving into your bloodstream stay in your gut, and you're going to lose it. And not only that, they pull water along with them. So you have raging diarrhea because of that autoimmune response. And especially if they eat something with gluten in it that flares up or inflames the gut, again, the gut will signal if something is irritating it. The person with celiac disease, when they eat gluten on accident, if they have a really bad allergy to it, they get raging diarrhea almost instantly. It's not pretty. So those intestinal crypts that I was telling you about on the previous slide, they dip down, and we still find simple columnar cells in there. We also find mucus goblet cells, mucus producing goblet cells. We also find in the submucosal region down there, Peyer's patches, and I'll remind you from our lymph chapter that those are a colony of B cells, a clone of one particular B cell. There are also glands in there that are releasing bicarbonate-rich mucus, and this helps neutralize the stomach acid coming from the stomach, obviously, once the contents from your stomach move from the stomach into the small intestine. So that bicarbonate-rich mucus helps neutralize the acid. There are also cells there that create a bactericide, and that helps fight bacteria that oftentimes gets into our body on the surface of the food that we're eating. It's always going to happen. Please do not take the advice of our president and imbibe bleach to kill those bacteria. Please let your Panath cells do their job. They will take care of that. So it's fine. These enteroendocrine cells that are found in the intestinal crypts are going to release 3 different hormones shown here on this slide. They are secretin, cholecystokinin, and gastric inhibitory peptide. Secretin tells the pancreas to release bicarbonate-rich mucus. This very much helps neutralize the stomach acid so you don't get an intestinal ulcer. Different enteroendocrine cell releases cholecystokinin. That hormone tells the pancreas to release digestive enzymes, and it tells the gallbladder to release bile. Bile is not an enzyme. Bile emulsifies fats, and I'll talk more about that later in this PowerPoint. Gastric inhibitory peptide tells the cells in your digestive tract to basically reduce their activity. Gastric inhibitory peptide basically says to the gut, slow down, and in particular the stomach. You don't want the stomach to empty all of that chyme all at once into the small intestine. The acid will chew through your intestinal lining, so you only want a little bit coming through the pyloric valve at a time. GIP ensures a slow release of the chyme from your stomach. That's why I said a typical meal can take you about 2 to 4 hours before it completely gets through the pyloric sphincter. And again, of course, I already told you about the duodenal glands also producing bicarbonate-rich mucus. The simple columnar cells of the small intestine also make digestive enzymes and not just absorb the nutrients. So they are helping with the chemical digestion. We hugely rely on the enzymes that come from the pancreas stimulated for release by cholecystokinin, as I just mentioned. But the small intestinal cells also make their own arsenal of digestive enzymes. Do not memorize all of these enzymes. What you should take away from this is the small intestinal cells make enzymes to break down carbohydrates into sugars. These cells also make enzymes to break down proteins. That's what a peptidase does. They also make an enzyme to break down lipids. That's what a lipase does. They also make an enzyme called enterokinase. Enterokinase helps activate enzymes that are coming from the pancreas. We should know from our first unit that proteins are made inside the cell from gene expression. We eat proteins. Enzymes that break down proteins don't discriminate the protein. Enzymes that break down proteins don't care if it's a protein you ate versus a protein that's found inside your cell. So peptidases are made in a precursor form. Just like pepsinogen is made in a precursor form and it has to be activated to pepsin. Why would we do that? These enzymes are also proteins. They are made from gene expression. You do not want them active inside your cells. They will digest everything that is protein inside your cell. You want these digestive enzymes that break down proteins to be active when they're in the lumen of your stomach and small intestine, where the food you ate is found. That's where you want them activated. Enterokinase activates those enzymes from the pancreas into active forms. And these enzymes that are activated, again, are enzymes that break down proteins. Their names are trypsinogen, chymotrypsinogen, and procarboxypeptidase. When they're activated, it's called trypsin or chymotrypsin, and then carboxypeptidase. But all three of those are enzymes that break down proteins. You don't want them active where they are made. You want them activated when they're released onto the food you just ate. Now we're into the large intestine. The large intestine has these features, these little pockets called haustra. And the haustra, I like to think of them as like a bundt cake pan. That's the reason why your poo looks bumpy. It's like they're just little pouches and your fecal material gets shaped to that form. So that's why when you poo, a lot of times your poo looks bumpy. It's because it's been sitting in these haustra. There are ribbons of smooth muscle called tenicolli. That's shown here, this ribbon of smooth muscle. And that smooth muscle is the reason why the large intestine gets puckered into those haustra. It's sort of like pulling on purse strings. The little packages of fat, thank you, little packages of fat that you're seeing hanging off here are little small pieces of peritoneum that's filled with fat, and those are called epiploic appendages. That's what those little tabs of fat are called. And I told you earlier that about 2 times a day you have mass movements, these peristaltic movements that help move feces into the sigmoid colon and rectum. Sigmoid colon is this S-shaped part here. The large intestine has an ascending colon. Then it has a right colic flexure. That means a 90-degree turn, also known as the hepatic flexure. transverse colon. Then it has the left colic flexure, also known as the splenic, and then the descending colon. So the hepatic flexure is the boundary between the ascending colon and the transverse. And the left colic flexure, or splenic flexure, sorry, is the boundary between the transverse colon and descending colon. Then we get to the, we also see these invaginations in the large intestine. So these large invaginations, these are called intestinal glands. Histologically, we see these invaginations here, lined by a lot of goblet cells. And the goblet cells are making a lot of mucus. So it looks like all this clear stuff is mucin. So that's an intestinal gland that I just highlighted. Here's a second intestinal gland right there. Here's another one that we can see. And again, lined with simple columnar epithelium and a lot of goblet cells. We need a lot of mucus production to lubricate our fecal material, making it easier for it to slide out of our body when we defecate. The bottom portion, or I should say the beginning portion of the ascending colon is the cecum. And that little circle that's there is the ileocecal valve. The appendix hangs from the cecum. This picture shows it hanging inferiorly. Actually, it's tucked up and behind the cecum. The sigmoid colon, again, is the S-shaped part here. And then finally, we get to the rectum and the anus. I told you about the teeny coli, the longitudinal strips of smooth muscle, the haustra, and the epiploic appendages. Here's a more up-close picture. The haustra with the little puckering, the teeny coli, this band of smooth muscle, the epiploic appendages shown here. Here's our ileocecal valve. Once the chyme passes through that from the ileum into the cecum, it is now fecal material. It is no longer chyme. Sigmoid colon leads to the rectum. The rectum has these folds in the mucosa called rectal valves. And there are also these valves here that create columns. These are called the anal columns. All of these structures are very useful because they allow us to pass gas without releasing fecal material. So you can pass gas without pooing your pants. Some of you like to push out the flatulence, and you run a risk of then these aren't really true valves. If you push out your flatulence, you run the risk of pushing out your fecal material. And then, as my boys would say, you just shart your pants for shit and fart, right? So don't overwork your anal columns and your rectal valves. You have two sphincters shown here. You have an external anal sphincter and an internal. The internal anal sphincter is involuntary. The external anal sphincter is the one that typically a 2 or a 3-year-old learns to master when they become potty trained. The internal anal sphincter, once smooth muscle, detects a lot of stretch from a lot of fecal material moving into the rectum, it will relax, and that's usually allows that receptive relaxation I was trying to tell you about. And then the toddler feels the fecal material moving, right? And all of a sudden cinches up their little butt cheeks and goes running to the bathroom. They're pinching it back with using their external anal sphincter. That's the part that they learn to master when they are potty trained. So your rectum is about 3 centimeters long. I told you about the valves. There's this thing called the pectinate line, where below the pectinate line, you actually have sensory information that you're consciously aware of. That's why when you feel your fecal material starting to crown, you feel that. If it's a big piece of fecal material and particularly desiccated and hardened, you might tear some of your anus, and you feel that. Thank you, pectinate line, for that. Internal anal sphincter, like I said, is smooth muscle and involuntary. External anal sphincter is one that we learn to master, and therefore that means it's skeletal muscle. Moving on to an accessory organ. We already learned about one, the tongue and the teeth, so I guess two. Let's learn about the liver. There are 4 lobes to the human liver. The right lobe is the biggest, and the left is the next biggest. Here is that falciform ligament that I told you about, which is a ventral mesentery. We have a remnant of the umbilical vein trapped into that, and we call that the round ligament of the liver. Here's the falciform ligament traveling through the liver here. Behind the right and left lobes, on the back side of the liver, I should say, we can see the quadrate lobe, quad meaning 4, because it looks like it's a perfect square with 4 sides. It's bounded by the falciform ligament on one side and the gallbladder on the other. And then here is the caudate lobe. So again, this picture shown here, we just flipped the liver up to look at the underside. We flipped up, not left or right. We just flipped it to see the underside. So that's why the gallbladder that you see peeking out here now looks like it's up at the top of this picture. Again, we flipped the liver. The porta hepatis, go ahead.
So just to be, I already know the answer. Obviously, we should all be paying attention to that, because in my mind, I always think, okay, caudate's tail is at the bottom, so if it gets tagged on the lab exam, but really just be aware of how they've angled. I guess it's just the gallbladder's next to quadrate, and that's how we should remember that.
Correct. And okay. Caudate, although it does mean tail, it doesn't necessarily mean it's at the bottom.
Okay.
It's tail shaped, or at least an anatomist thought it was.
Okay.
So that's why technically it would be up at the top of the liver, right?
Yeah.
By the vena cava.
Okay.
Yep.
Got it. Thanks.
So porta hepatis is basically where all things enter or exit from the liver. The porta hepatis, if we're talking about things entering, we would have the hepatic artery coming from the celiac trunk entering, and it branches into the right and left hepatic arteries, bringing blood to the liver for nutrition. We also have the hepatic portal vein bringing blood to the liver for the sake of being detoxified. So the hepatic portal vein, part of the hepatic portal system, is bringing blood not for the sake of delivering oxygen and nutrients, but for the sake of the liver to do its job and cleanse the blood. The liver actually has over 500 functions in the body. Detoxifying blood from your gut is just one of many. It also makes bile. Bile is made by the hepatocytes. It also helps manage cholesterol, like LDL and HDL, that stands for different types of cholesterol molecules. It also makes some clotting factors for you to clot your blood, just to name a few. The thing that exits the porta hepatis would be the common hepatic duct. So the right we see up here the right and left hepatic ducts. They converge to form the common hepatic duct, which exits through the porta hepatis, and that will merge with the cystic duct from the gallbladder to form the bile duct. And I'll show you another picture of that in just a moment. So I already told you about the right and left lobe and the quadrate, which is bounded by the gallbladder and falciform ligament, versus caudate. There is a bare spot on the diaphragm up the top, and that's because it's called bare because it is firmly attached to the underside of the diaphragm, and that means the visceral peritoneum could not envelop all the way around the liver. So there is no visceral peritoneum there. It looks kind of rough when you see it from a human cadaver. The round ligament, I already told you, is a remnant of the umbilical vein. Round ligament also is called ligamentum teres. We also remember our fetal circulation. We remember our ligamentum venosum, which is not shown here in this picture. And then lastly, the hepatic vein. Hepatic veins, not shown here, they would be emerging from microscopic structures I'm going to show you, taking cleansed blood, but oxygen poor, from the hepatocytes into the inferior vena cava. Again, that would be cleansed blood that can now be distributed to the body. So this microscopic structure that I'm going to tell you about, this is called a lobule. It has a hexagonal appearance. The lobule is the functional unit of the liver. We see, like pages in a book, these rows of hepatocytes. Their job is to cleanse the blood that is showing up through the branch of a hepatic portal vein. As the blood goes from this branch of the hepatic portal vein, it will dump into this area called the central vein, and all the central veins will combine to form hepatic veins to dump into the inferior vena cava. This structure out here that I'm circling is called a portal triad. There are three things in a portal triad. They are branches of something. We have a branch shown here in green of the bile duct. We have a branch of the hepatic artery, bringing oxygen-rich, nutrient-rich blood to the hepatocytes to serve their needs. And we see a branch of the hepatic portal vein, bringing blood to the hepatocytes for them to cleanse and detoxify. So these liver capillary beds here, that is connecting the branch of the hepatic portal vein to the central vein, those are called liver sinusoids. It is basically a capillary. They are very open or discontinuous, we say. And this allows the hepatocytes to cleanse the blood as it flows from the hepatic portal vein branch to the central vein. In this picture, if you look very carefully, we see the right and left hepatic ducts of the liver. They converge or merge to form the common hepatic duct. The common hepatic duct merges with the cystic duct to form the bile duct. The bile duct exits, basically is coming off of the liver, I should say, and merges with the pancreatic duct in the pancreas, and where the two merge is at the hepatopancreatic ampulla. And a sphincter, a circular band of smooth muscle, regulates if the bile and pancreatic enzymes are allowed out into the duodenum or not. If the bile is made in the liver, why do we need a gallbladder? The gallbladder stores and concentrates the bile. And when you eat fats, the cholecystokinin, the hormone that I told you about, tells the gallbladder to release the stored and concentrated bile. And this helps you emulsify your fats. If you do not have enough bile released when you eat fat, you will have a nasty kind of diarrhea called steatorrhea. Bile is not an enzyme, but bile is necessary to take large fat droplets and basically reduce them to many smaller ones so that the lipase, the enzyme that breaks down lipids, can get to it, like more surface area. If you don't have this surface area, then the lipase doesn't digest the lipids very well, and you will have steatorrhea. That means fatty diarrhea. Sometimes these bile salts can precipitate in the gallbladder and form gallstones. And these gallstones can get lodged in the bile duct, very painful. The smooth muscle lining the bile duct constricts and tries to get these stones to pass through. Extremely painful. If you can't get them to pass through, you might have to have a procedure where they use ultrasonic sound waves to kind of break up the gallstones into smaller fragments. And if you have a great propensity to do that, they will likely remove your gallbladder, which means then in the future, when you eat fatty food, you should not eat too much of it because, again, the gallbladder is missing if they took it out. The liver doesn't have the ability to store bile, it makes the bile. And the bile kind of dams up behind the hepatopancreatic ampulla into that bile duct. So you're just not going to have a lot of it for any given meal. So you don't definitely, if you have your gallbladder removed, don't eat a lot of fat all at once. Another set of information I want to tell you is this duodenum. It's part of the small intestine, of course. It's not an accessory gland, but in that little C-shaped nook of it, we see an accessory gland called the pancreas. And it has the head, shown here, the body, and then out here by the spleen is the tail. The pancreas is a mixed gland. It has two different kinds of cells. It has pancreatic acinar cells, shown here in this picture. And then it has these cells that stain differently, called pancreatic islets, or islets of Langerhans is what they're sometimes called. And I'm going to talk about those in more detail. But again, the pancreatic duct allows pancreatic enzymes and bicarbonate-rich buffer to come out of the pancreas. It joins with the bile duct, so the bile coming from the gallbladder, and then all of that will exit through the hepatopancreatic ampulla and sphincter into the duodenum and help neutralize stomach acids and also start a lot of the digestive process. So here is a histological picture of the pancreas. These light colored, they almost look like clouds. Those are the pancreatic islets. All the dark pink stuff here are the acinar cells. The acinar cells make up the exocrine function of the pancreas. They make and release those pancreatic enzymes and bicarbonate-rich buffer to neutralize the stomach acid and to start breaking down the food that you just ate in very robustly. So most of our digestive enzymes are coming from these acinar cells. The pancreatic islets have two main kinds of cells, beta cells, that make insulin. Insulin is released when your blood sugar levels start to go up after a meal. And insulin allows cells of your body to pull the sugar into the cells. And glucagon are made from alpha cells, and glucagon tells the liver that blood glucose levels are low and the liver needs to release more glucose into the bloodstream. The liver stores a lot of the glucose we eat in the form of glycogen. So in between meals, glucagon tells the liver to release the stored sugar. Between those two hormones, that's what regulates our blood glucose levels. So again, we have the right and left hepatic ducts. They merge to form the common hepatic duct, which merges with the cystic duct to form the bile duct. Some books call it the common bile duct. Either one is fine. And then the bile duct merges with the pancreatic duct at the level of the hepatopancreatic ampulla. And then those secretions, bile and pancreatic juices, come through into the duodenum through the major duodenal papilla. There are other cells in the islets of Langerhans, not just alpha and beta. There are delta and there are even F cells. Our main focus for anatomy is going to be the alpha and beta cells. The enzymes that are made and released from the pancreas, we have 3 that I already told you about that are made in a precursor form that are activated by enterokinase that I told you about from the small intestine. Those break down proteins. So notice here, they break down protein. Peptides are small proteins. Sodium bicarbonate, that helps neutralize the stomach acid. There are other enzymes like amylase to break down carbohydrates, lipase to break down fats, and 2 sets of enzymes to break down nucleic acid material that we ingest in our food. It's weird to think that when we eat an apple, we are eating cells, and those cells have nuclei and they have DNA and they also have RNA as well. And we can use those nucleotides for our own nucleic acids. Real quickly, you do not need to memorize this slide. It's just showing you color coordinated the enzymes that we have in our body to break down carbohydrates. Carbohydrate digestion begins in the mouth and continues in the small intestine. So that's the important part here. We also have, in the small intestine, we have enzymes coming from the pancreas, but we also in the small intestine have enzymes breaking down sugars that came from the simple columnar cells of the small intestine itself. Digestion of protein starts in the stomach, continues in the small intestine, thanks to pancreatic enzymes, but also enzymes that came from the small intestine itself. We also have a lipase that is digesting lipids as well. Your pancreas is making most of those digestive enzymes, and if you have pancreatic failure, you will not be able to digest the food you eat very well. The enzymes that come from the small intestinal cells are not sufficient for proper breakdown of the food you eat. So without that, you're going to have a lot of diarrhea because you can't absorb those nutrients. And if you can't absorb them, they leave the body and they pull water with them. How can you have pancreatic failure? Your pancreas can get inflamed and irritated. And if it does that, it can start to lose function. And here's how and why. If the pancreas starts to fail, those 3 enzymes that I told you about that are stored in the pancreas but should not be activated, like trypsinogen, chymotrypsinogen, and procarboxypeptidase, If the pancreas starts to fail, those enzymes will activate each other. Sort of like someone killed the babysitter and these 3 infants will now go rogue. They will start to digest the pancreas. You will feel that. When you start to digest yourself, in particular your pancreas, you will know what day it is, what hour it was, when you first had that flare up, when you felt that pain. When it happens once, just randomly, acute pancreatitis, it's usually because gallstones have blocked the hepatopancreatic ampulla, dammed up all the pancreatic enzymes in the pancreas, and they started to autocatalyze each other. But a person can have frequent flare-ups of pancreatitis, and that's called chronic pancreatitis. Number 1 cause of chronic pancreatitis, where you have this flare-up about 3-4 times a year, is alcohol abuse. If you have chronic pancreatitis and you do not get that under control, you are not long for this world. You are not long for this world. It is extremely painful, and we are not sure why alcohol causes this chronic pancreatitis. We do know that the liver and pancreas are in close proximity to each other, and we know that they communicate to each other. So if the liver is overworked because of frequent alcohol use and abuse, the pancreas somehow gets that signal and gets inflamed. It too starts to not perform well. If someone is hospitalized, and they will be, for pancreatitis, regardless of which kind, they are in the hospital for a while. We're talking about 2 weeks. And most of that is for pain management. That is mostly what they're in the hospital for. It is that excruciating. And second to the pain management, we're also trying to get those 3 bad kids, those 3 enzymes that got activated, somehow tethered and back in control, not still catalyzing each other into active mode. So that takes some time to kind of subdue them. And we talked already about peptic ulcer disease, and this is what it looks like when your pyloric region is healthy in picture A, but this is where an ulcer has broken through and now the person has a bleeding ulcer. If you have an ulcer in your stomach, it's called a gastric ulcer, and if you have it in your small intestine, it's usually going to be in the duodenum, so they call it a duodenal ulcer. When a person has a gastric ulcer, it's usually because they've lost the ability to protect the gastric mucosal layer, the simple columnar cells. Well, how can a person lose that protective ability? Abusing aspirin, NSAID abuse. People who have chronic arthritis, for example, or other aches and pains, if they're taking daily aspirin, aspirin impairs the stomach from making mucus, and the mucus slathers on the surface of the lumen of the stomach and protects those simple columnar cells. So if you're taking aspirin all the time and heavy dosages of it for pain, you're a ticking time bomb for an ulcer. Smoking also destroys those mucous neck cells. Stress also can impair them, and alcohol abuse. Those are the big culprits. If we find someone that has gastric ulcers and we rule out abuse of aspirin, abuse of alcohol, rule out smoking, rule out stress, the number 1 cause, once we rule out those, is actually a bacterial infection. And shown in green, and they're not really green, it's just kind of colored so you can see them. Those are Helicobacter pylori, or H. pylori. Bacteria can cause ulcers. And the scientist that studied H. pylori and realized that they could cause ulcers, to prove his point, he infected himself with H. pylori, just to prove to the scientific community that they can, in fact, cause gastric ulcers. Now that's bringing your work home with you. Duodenal ulcers, ulcers found in the duodenum, are usually a problem with too much acid production by the stomach, so that the pancreatic bicarbonate buffer can't neutralize it enough. And that's usually when the person needs the purple pill, you know, the Pepsid-AC pill. And that's it. So I am going to stop sharing my screen and unmute you all. We have reached the end of our class. If you give me just 20, not even 20 minutes, just give me 15 minutes, I'll have your quiz ready to go for you, okay? But you have until 11:59 to take it tonight. All right?
All right.
Okay. All right. Then I will talk to you all on Wednesday.
Thank you.
Thank you.
You're welcome. Bye.